Alan is not only well known, but he's also highly flexible, and he's and Alan's going to talk about COVID-19 vaccines.
It's a surveillance committee, which is probably about to change to the respiratory infection surveillance committee. I've recently stepped down as ACV and no longer on AHPPC. And obviously the views in this presentation are about mine and not about any of these committees or organisations. So I thought it's a bit intimidating going between Terry talking about all the new vaccines coming and Gary when he talks, and then Katie, who's going to talk about a targeted vaccine policy. So I thought I'd take a step back and actually take a leaf from, this flows on well from what Terry said about real world evidence, and talk about some of the limitations and advantages of the different data sources that we have, and then some of the implications. So I'm not going to talk about the vaccine policy, and Katie will talk about this in the next session. So vaccine effectiveness, obviously, is the reduction in the risk of outcome. So you have, so you can either do it as a case control study or a cohort study. And the idea is that you have a group that are vaccinated and a group that are not vaccinated, or some similar comparator group, and you measure their infection rates, and then the ratio of that is reflects their vaccine effectiveness. The first point here is that the choice of a reference group is now becoming quite important. It's very hard now to talk about vaccine effectiveness in real compared to non-vaccinated people, because so few people are unvaccinated, and that and the characteristics of that group are now quite different to the rest of the population. So we often are looking at what we term relative vaccine effectiveness. So what is the advantage of 4 versus 3 doses, and so on. So when we are not randomizing and doing this in a clinical trial, we need to think about this we need to think about confounders and biases, and age is probably a very good example of this. Older people more likely to be vaccinated, more likely to get severe disease, and we can draw these diagrams. There's a very good example of what is Simpson's paradox, which I've never been able to explain to students before, but for the first time I can now. So if you look at the unvaccinated, this was in June of 2021 as the vaccine programs were rolling out. The mortality ratio in unvaccinated people was quite low, and those who were vaccinated was much higher. So that made it look like there was, vaccination made mortality higher. But of course, the explanation is that there's very strong confounding by age, and we were vaccinating people who are older. And then once you stratify by age, then you can see these very strong protective effects. And this is a very good illustration of Simpson's paradox in epidemiology. And there's a way of thinking through all of these known as directic acyclic graphs that's becoming increasingly common in epidemiology. And the idea is that not everything is a confounder, and not everything needs to be adjusted for, and there are pathways. And the idea is that you need to block some of those pathways to get an unbiased approach. And some things are mediators, and some things are descendants, like long COVID in this case. So these things do not need to be adjusted for. And in fact, if you do, then you'll end up in more trouble than you started with. And so Sheena Sullivan tells me that there's a lot of papers on this coming down the line, but the best paper is actually her one from pre-pandemic, where she considered a lot of these directed acyclic graphs in the assessment of influenza vaccine effectiveness in the context of test negative studies. And the idea is that, for example, socioeconomic status per se doesn't cause severe COVID, but it's mediated by previous infection because of increased exposure or reduced health-seeking behaviour or deliberate policies to try and get people vaccinated. So you need to try and break those pathways, but not necessarily adjust for everything in the kitchen sink that you have. So the most obvious confounders for influenza and for COVID vaccines is by indication. So we deliberately vaccinate people who are who are more highly at risk of getting severe disease to reduce that risk. There's a healthy user effect, which is the opposite. So people who get vaccines early are those who are good at taking care of their health in other ways. So probably more likely to use masks and might have a lower risk of severe disease because of that. There's time that we need to control for carefully because exposure is changing, as well as vaccination coverage over time. And health-seeking behaviour is quite difficult to control for. People have looked at things like, uptake of aspirin or statins or other things, assuming that aspirin and statins themselves don't cause a reduced risk, but are a marker for health-seeking behaviour. And there are a lot of potential cohort effects. So, the very first group that were eligible, obviously at higher risk, but obviously, if you got vaccinated in the first week of the vaccine campaign, you're probably most motivated to avoid infection. So therefore might be more likely to use masks and to stay at home and try and avoid infection. So thinking of the data sources we have, linked data is the flavour of the month, and we'll be doing a lot of studies in this. And this is really to use the power of the whole population, and it's very high statistical power. There's now, we now have the opportunity with the Australian Immunisation Register having mandatory vaccination of COVID and flu vaccines. But there are some pitfalls here. So firstly is that there's potentially differential ascertainment of some information. So in people that have COVID, they may have been more likely to be hospitalised in the past, and therefore we know that they have diabetes. And so that with a lot of this administrative data, you can't really go back and sort of question it or clean it up that much. You're really reliant on what you have. As my children say, you get what you get and you don't get upset. And then some outcomes may not be coded accurately. So COVID hospitalizations, we can't really tell easily with COVID versus for COVID. In the old days, a lot of flu hospitalizations, those diagnoses were made clinically and not confirmed by PCR, but that obviously has changed over time. And then there can be difficulties in defining the cohort. We did a study with Betty Liu where we were looking at flu vaccines and antibiotic use. And we had all these problems about trying to define actually who was still being seen by a particular GP. Had they moved to another GP, or had gone overseas or interstate or elsewhere? And trying to find who is actually still within a cohort can be somewhat difficult. For COVID, who moves across a border or who seeks healthcare across the border can be issues as well. So with Betty has been driving this work looking at linked data, linking the immunisation register to the New South Wales COVID notifications and death registrations. This was done in the Sydney and the Hunter New England region, again, to try and avoid some of those border issues, and obviously the bulk of the New South Wales population being there. So the way we looked at it was to consider vaccination as a time-varying covariate. So you're not vaccinated, then you get 1 dose, 2 doses, and there's times after various doses. And then that could be adjusted for age, gender, socioeconomic status, and so on. And comorbidities were ascertained from hospitalizations, but hospitalizations that had occurred before the start of the study period, because we didn't want everyone who had been hospitalised with COVID to have all these comorbidities to be found that the controls didn't have that because they weren't hospitalised. So you need to be careful there. And so this is these are the results from there to show that to compare some of the risks of infections. Again, there's all the issues of who are getting these vaccines. Probably matters a little bit. So people who have waited for later vaccines may well be different in many ways, and we can't always adjust for all those issues. The UK Health Security Agency have done this very well. They've used a test or case control design with a negative test selected at random, and then adjusting for that long list of factors that you note there, and particularly things like those who are clinically vulnerable and healthcare workers and clinical risk group is obviously quite a powerful tool. And so they've produced these very helpful estimates of vaccine effectiveness. They're still talking about vaccine effectiveness rather than 2 versus 3 or 3 versus 4 doses. And obviously that depends on that group that is still unvaccinated there. The comparator, at least for some of these, has been 2 doses greater than 6 weeks, and trying to align that with policy relevant questions. So sentinel surveillance systems are much smaller and have much lower statistical power. And that actually impacts on the timeliness, because if you need to accumulate a whole lot of patients, you have to wait a lot longer. But that does provide the opportunity to collect a lot more clinical data that you wouldn't be able to pick up from an administrative data set, such as smoking and body weight, for example. And we have a very specific outcome, so we can actually confirm that there is a PCR confirmed hospitalization, can work out whether it's incidental and so on. There can be issues with the control, so you can't always work out, if there's a control group, what population does that represent? It's a population that are likely to be hospitalized, but you can't easily define what that cohort is. So an example is the study that we've been running for flu, which is but now adapted to COVID, where we've adapted case definitions for cases and non-cases, or test negative design, with the analysis stratified by date and then adjusted for various factors. And what we can show here is that, for example, that in the elderly, there is a benefit of 3 and then 4 doses, and that benefit is increased. And then these estimates are similar against BA1 and 2 versus 4-5, similar in all adults to the elderly. Over time, there is waning, so that 6 months after a 3rd dose, it's equivalent or similar risk of infection to very soon after a 2nd dose. And there's still looking at the data for time after 4th doses. The EU network have taken a similar approach. They've prospectively enrolled patients with severe ARI. It is noted that in this study, they do require consent to participate, so this isn't really a surveillance system, and therefore there are potentially biases that are introduced by that process, and they have other inclusion and exclusions which are relevant. And then the US CDC have their own similar system at specific clinics. These are, I understand, testing sites that are directed towards trying to improve access for other disadvantaged and hard to reach populations. But they've been able to look at vaccine effectiveness against XBB variants that are common there, and then stratify them by age and time after vaccination. So there's a lot of heterogeneity, as you can see. There's not only the population type, the vaccine types that are used in the country, the number, the timing of vaccines, and so on. And there's a lot of confounding by natural infection, and then the variants that are common, which are now becoming more diverse across and different between some countries. And then that's even before all these methodological differences about, what exactly the endpoint is and what, what's being adjusted for and so on. So the findings that are consistent is that protection against pre-Omicron variants had been quite high, but is much lower against Omicron, at least against infection, and that's lower than against severe disease. There is this waning protection over time, and the incremental benefit of boosters is decreasing. So the bang for the buck with getting any vaccine at all is much higher than the 4th or 5th dose and so on. So the implications for surveillance and research is we really do need better systems in Australia to monitor vaccine effectiveness. And now that NINDIS, I think Ian mentioned this yesterday, after 18 months, we have an extra I in the acronym, and that's the interoperable national surveillance system. we've really lost track of who actually has COVID now. There's, PCR testing is no longer as relevant as it was, and we really need to focus on hospitalisation and death as the most important endpoints, and then perhaps long COVID has been pointed out. Linked data is quite powerful, has very high statistical power, and is very timely, but there are other methodological issues that need to be thought through. And I think the best use of it is really to complement other methodologies to make sure that everyone's on the same page and that everything seems to make sense. I'll talk a little bit about neutralizing antibodies. Obviously the first studies that come out when there's a new variant are these neutralizing antibody studies, but how we relate that to vaccine effectiveness still isn't completely clear to me. Does doubling the antibody really change vaccine effectiveness much, or for how long? And then as we get better vaccines, as Terry's talked about, we will need to evaluate them and compare them, and there won't be comparative trials to do that. So we need to have systems, ongoing systems to monitor vaccine effectiveness. And so these studies that Tony mentioned yesterday that measure antibodies really need to be combined with vaccine effectiveness reports, and Deb Cromer and her colleagues have done this great work in trying to correlate vaccine effectiveness against antibodies, and then that can be used for modelling studies to say what is the likely population impact of introducing a new booster or new vaccine. So vaccines really are only partially effective, and I think preventing transmission now is really impossible. The main population who transmits are the people that are at lower risk of severe infection, and the coverage with each incremental booster is falling, and most particularly in younger people. Also, I think the disease is changing. Working at the Alfred. We don't really see people going to ICU with pneumonitis anymore. There's the occasional patient that does, but most of them are now, geriatric syndromes, delirium and, falls and impairment of homeostasis. So whether vaccines, and I think antivirals as well, that mechanism of how that impacts on that, I think probably needs to be reassessed. Everyone's either had a vaccine or probably had an infection now, so I think thinking of vaccine effectiveness in absolute terms is probably no longer possible or relevant to policy. So we really need to think through what is the incremental benefit of additional boosters, and then make sure that we design our studies accordingly. So I'll finish there, and just like to acknowledge Betty Liu particularly, and then my collaborators in Flucan and Sheena Sullivan and Stacey Rowe for all the work they've been doing. Thanks very much.
Alan, thank you. Monash are very lucky to have you as their new leader of ID. Questions?
That not everyone's the same, and so Gay Waterhouse, Malcolm Turnbull and Pauline Hanson are all the same age, but we figure they're different people. So the context of what's the right treatment for an individual that's in front of you versus the research that as you said, there's confounders, confusers, and things to take into account and some things not to. So from a policy point of view, doesn't that mean that you have to switch back to more responsibility rather than a policy says, if you're 64 3/4, you can't have a vaccine because you have to be 65? Like how do you put that policy and the clinical need sort of together so that it's not actually impeding antivirals, vaccines, fourth dose, all that sort of stuff?
Yeah, I mean, so I'll let Katie talk about sort of policy and recommendations, but I mean, you do need to draw lines at some point. So there's clinical recommendations, and I think that sort of flows into what you're talking about. But there are funding decisions that need to be made, and the government will fund or not fund flu vaccines, for example. So I think we will always have those lines. And in the end, we need to, when we design studies, we are generalizing from a population to, from sample to a population, and then that to the individual members of the population. So unless we can define who it is that a vaccine is going to benefit to and how much. And then, we need to think about its cost effectiveness. There will always be these lines, I think. And I do recognise that, as you say, there are people right on the border. There are people that are, frail that are 64 that will probably benefit. But in the end, you have to have a policy that is workable and, that is funded and supported.
Yes.
I wanted to ask you about the prospects for clinical data linkage in Australia. So you highlighted, AIR is a wonderful system. We know who's got vaccinated. There's Cialit in Israel and then, UK. So what do you think the prospects are? And you spend a lot of time with this, linking all these clinical data sets. Is it feasible? What do we need to do? Is it really a massive investment and a clean sheet, or are there systems that can link these data systems effectively in Australia?
There's a lot of linkage infrastructure around, and every state has a linkage unit, but generally they're two big databases that the state holds. So the APS and AHW done that at a national level. They can link tax databases to vaccine databases to and work out what language people speak and those sort of things. But what we really need is actually, it's the hospital databases, and which we can't easily link. And so that's what what the advantage in Israel had was, single national identifier. They could work it out within their system at Clalit or their HMOs, and they had the hospital databases to work with, so they could do those linkages easily. And that's what we can't do. They started on this 20 years ago and have got all this a lot of lead time. And I think the other advantage that what will drive that is that a lot of that improves clinical care, and that's what we need to sort of make sure that we keep our eye on, to say all these linkages are really useful, they're good for research and for this sort of thing, but if they enhance clinical care, then we need to adopt them eventually. And clearly over the last couple of years we have a EMR in a hospital, and that's an advantage, but now we need to start using that and try and link it up to other systems.
Alan, thank you. Another thing to do, improve data flow.
Right.
Yeah, absolutely. Terrific talk.
Nice,
Thank
thanks.
you.